Thanks, everyone. I appreciate the last talk, and we're tight on time, so I'll try and keep it brief. But I'd like to thank the HRB and the conference organisers for giving us the opportunity to speak today and to present some of our research. I'm going to talk about emerging global health threats and how Ireland can react, but I'm going to use the example of Mpox because it's very topical at the moment. You've probably seen it in the media. We've had our first Clade 1 imported case. And I'm going to talk about what we've done in UCD and with colleagues around Ireland and how existing research infrastructure has helped. So just a brief refresher on Mpox, because I'm sure you all know this. It's orthopox virus, which has been endemic in Central and West Africa for many years. It's spread by close person-to-person contact. There's classically been two clades. The first one is the Central African clade, which is reported previously to have a case fatality rate of up to about 10%. And then there's a less virulent West African clade with a case fatality rate of much lower, about 1 to 4%. It's been suspected that smallpox vaccination, as it's another orthopox virus, gives protection against Mpox infection. And to that end, MVA, which is a modified vaccinia virus, which is used for smallpox prevention, was licensed under emergency legislation for use in the US and EU and elsewhere for Mpox prevention in 2022. However, data on Clade 1 is extremely lacking, and the data on the longevity of the immune response is also lacking. And this came to the fore, and the reason it was licensed was because of a 2022 outbreak. And you could be cynical and say this vaccine was licensed once the virus began to spread, particularly among people in the developed world. Apologies. So there was initial cases noted in London in May 2022 in a traveller returning from Central Africa. But then the virus cases began to crop up all over the place. And cases were predominantly noted, this outbreak almost entirely happened in gay and bisexual men who have sex with men. And thankfully, this was a Clade 2b outbreak, so this Clade 2 virus was much less pathogenic. The WHO declared this a public health emergency of international concern in July 2022. And by the time it declared it over in May 2023, there was approximately 100,000 cases across 121 countries. But thankfully, the case fatality rate was extremely low at only 0.2%, and predominantly in people with significant immunosuppression. We saw a similar pattern in Ireland, where we saw an increased rate of cases into August 2022, which dropped off afterwards. But we have seen persistent and ongoing cases since then. And some of these have been interesting, and I'll tell you a little bit about why. So what do we do about that? So we had a relatively new emerging pathogen, and we have this tool called the All Ireland Infectious Diseases Cohort. So this is a prospective cohort study, which was started by Paddy Mallon in the Mater Hospital probably about 2009, and has gradually grown to now involve 11 different sites. It's NREC approved, and all patients attending these sites who are attending for treatment of infection or infection-related issues, including vaccination, and can be offered to participate, and they can have their clinical data banked, and blood, swabs, other biological specimens banked as well. And as of this month, we have about 5,400 subjects recruited across all these sites. And what we've been able to do with this vaccination, there is no serological test for Mpox. So this is data just been published by Joanne Byrne, who's one of our PhD students. And she was able to develop an Mpox assay that not only looks for the presence of antibodies, particularly to the MVA vaccine, but also can delineate the difference between infection and vaccination. And it performs very well. In a because this is a prospective cohort study, patients are only attending for follow-up over a period of time. She was able to look at the change in response in individuals who are presenting with Mpox infection, who had their samples biobanked and returned for follow-up afterwards, and also our patients who are returning for post-MVA vaccination, because many of these were attending what's called our PrEP clinic, our PrEP service, so they're attending every 3 months, and they're usually very happy to partake in research. And what Joanne was able to show was it looks like, but this isn't a strict follow-up, rigid kind of observational study, prospective study, was that there was a fall-off in serology antibody levels, particularly in the vaccinated group as opposed to the infected group. And by 1 year, only about 25% of people had a significant, what we call a seropositivity when we used a predefined threshold. This is important because this individual who has given us their written permission for me to use this photo walked into our clinic about 2 weeks ago, and he was vaccinated against Mpox at the time of the 2022 outbreak. And he presented for routine care. One of our astute nurses said, "What's that on your nose? Do you mind if I swab it?" And when he swabbed it, it was positive for Mpox by clade 2 by PCR. So this is a person who has been vaccinated 2 years ago by a vaccine that's supposed to prevent this infection, who's presented with, albeit a very attenuated infection. So we want to know what's happening over time, and for that reason, the HRB has funded again, thank you for funding the Mpox study, which is a study looking at the rate of change and the durability of antibody response with MVA-specific antibodies, particularly after a year of vaccination. And we're recruiting our subjects in at 5 visits over 48 weeks after their first dose. But we've got a lot of very important secondary endpoints looking at the development of MVA-specific antibodies at 6 weeks, the neutralizing capacity of the serum that's been produced, and also the presence of asymptomatic Mpox infection. Because if there are individuals presenting with a very small lesion in the nose post-vaccination, which turns out to be Mpox on PCR, we postulate there may be people who are getting infected out there who may not even know about it. So what tool we use to roll this study out is actually the Infectious Disease Clinical Trials Network of Ireland, which was another HRB-funded project, funded in 2021 on the back of the SARS-CoV-2 pandemic, which is to, as you know, many clinical trial networks that HRB funds, to improve the clinical trial infrastructure in ID in Ireland. And there's been 6 sites associated with academic ID departments in Galway, Cork, and 4 in Dublin as well. And we've already been involved in several studies in HIV, the SWIFT study looking at semaglutide in people living with HIV, SARS-CoV-2, the 002 study looking at tocilizumab, and then vaccine studies along with European partners, that because we're members of a CTNI, we've been able to come to the table and say, can we partake in these studies and lead out on many of them. The issue we've had, and maybe this is something for discussion later, is that everyone's very anxious to do research. Our patients are very anxious to take part, and the study is up and running. But we've had significant issues in the legal and kind of operational rollout of these studies, particularly around things like CTA negotiations. And we're finding that our UCD is a sponsor. They have to negotiate with 6 different sites for 6 different CTAs. Each site comes back with different issues. You reply. Sometimes the sites come back with new issues. So it's really been a bit of a roadblock to getting the study up and running. In addition, there's been other problems such as the data protection piece that I think Helen mentioned, and shortages of vaccine and shortages of study nurses as well. And this is important because, as you're probably aware, that 2022 outbreak has ceased, but there's an ongoing 2022 outbreak that's currently persisting in the Democratic Republic of Congo. This is a clade 1 virus infection. It's predominantly in DRC, but there's 25 countries in Africa overall. And to date, there's been about 24,000 lab-confirmed cases, though we estimate the number is significantly higher than that, and 93 lab-confirmed deaths. This is a very different outbreak. This is an outbreak of a different virus, a different clade of virus, but much more in women, kids, outbreak in households as well. As you know, there's been several cases imported into the EU, including imported into Ireland here a couple of weeks ago. And as we said, the data on vaccine efficacy in clade 1 is very lacking. We've got a bit of data in clade 2, but it's all predominantly in men, and data on efficacy in women and children is also lacking. So on the back of our AIID work, which we had the cohort work, on the back of our antibody work, on the back of the effect of the clinical trials and being able to roll out Mpox vax in Ireland, and we were recently successful in EDCTP funding to adapt and roll out Mpox vax in an African setting. So we're collaborating with collaborators in Uganda, the DRC, Tanzania, and the UK to adapt and roll out Mpox vax and what we're calling the Mpox vax AfriVac. And we see this as having several key objectives. The first one is to actually roll the study out in areas that are predominantly being affected by the current clade 1 outbreak, based off the Irish Mpox vax study that we've designed, using the assay that we built and designed here in Ireland, but also we've got African researchers coming over to us in the next few weeks to actually learn how to use and operationalize the assay. And to look at it look at the response to vaccination in a very different population. Not only is it's more African individuals, but also more women and those with immunosuppression, and to establish and roll out clinical trial units within these countries so that we can be prepared for further emerging infections that may arise in these areas. So to conclude, emerging infections, we weren't expecting this. We weren't expecting the next pandemic to be a coronavirus back in 2020. They can and they will arise suddenly and unexpectedly. But I really think that with well-established pre-existing research infrastructure, data on emerging threats can be quickly obtained. I can't echo this enough. Our patients are fantastic. They're highly committed to research and participation, and we need to facilitate that for them to take part. But the presence of well-funded, established infrastructure with a proven track record allows Irish researchers to compete for and collaborate in the wider EU research-funded programmes. However, I think we need to get our own house in order a little bit, and despite lessons learned from SARS-CoV-2, I think there does exist a requirement for better streamlining of our processes, particularly at a legal and institutional level, to facilitate quick and safe clinical trial rollout. So thanks for your time.